Thank you, Torosila. Thank you all for your patience and attendance. I'm already tired, so I would try to give a brief presentation about the infraclavicular approach for management of venous thoracic outlet syndrome. And I would start by a case presentation, which was actually my cousin. She presented 3 years ago with recurrent right arm and hand swelling with pain and heaviness. But actually, when I saw her, I didn't see anything. But she claimed that she had that recurrent swelling coming and going, but became more frequently in the past years. So I asked for some lab results. I advised her to do a mammography, and all were normal. So I reassured her. After a few weeks, she called me on the phone because she lives in Cairo, I live in Alexandria, so she told me she's having this swelling again, and it's really, really hurting her. So I referred her to a colleague in Cairo who did a duplex who suspected DVT, as she was really having swollen limb. And the duplex returned with no DVT, normal duplex, and they prescribed some venotonics and advised some elevation, after which she partially improved. So I told her, come over, I will do a workup for you. Our workup entails plain X-ray, which returned normal, no cervical rib. Nerve conduction study was also normal, so we do a dynamic duplex scan in hyperabduction position, which revealed actually flattening of the wave in the subclavian and axillary vein, and that gave us a hemodynamic diagnosis of the presence of venous thoracic outlet syndrome. CT venography was then done, which confirmed the diagnosis, the subclavian vein to be compressed at the costoclavicular junction. And when we're talking about thoracic outlet syndrome, we're talking about three structures that can be compressed indeed: the nerve trunks, the subclavian artery, and the subclavian vein. And there are three syndromes resulting, and there are three stations: the costoclavicular space, scalene triangle, and the subpectoral or subcoracoid space. And specifically, venous thoracic outlet syndrome had three clinical presentations. One, the most popular, is acute upper limb DVT, where the patient presents with acutely swollen upper limb with deep vein thrombosis. And this situation, these patients usually are young patients having the DVT in their dominant arm. So anticoagulation alone actually usually results in high long-term morbidity for these patients. So we do catheter-directed thrombolysis or mechanical thrombectomy, followed by first strip resection to decompress the thoracic outlet. The second presentation would be if the patient was treated by anticoagulation. The patient may later present with chronic post-thrombotic syndrome with some visible veins around the shoulder. And in that situation, you would need to decompress to do first strip resection with surgical or endovascular reconstruction of the vein. One of the severely underdiagnosed conditions is actually called McLeary syndrome, which is the non-thrombotic venous thoracic outlet syndrome, as my cousin presented. Actually, these patients suffer from intermittent arm swelling and pain, which usually goes undiagnosed for long. And these patients, we need to decompress the thoracic outlet area. So the challenges with these patients, actually, some related to the diagnostic challenge because it needs to be dynamic rather than static. The other challenge is the type of patient, as we mentioned before, and the dominant arm in young patient is something to be looked for seriously. We cannot estimate the true incidence of that condition, and whether it predisposes to later DVT, no evidence has shown that, but actually it makes sense that the continuous irritation of the vein or compression at the outlet may predispose to development of DVT later on. It's not new. Upper limb venous compression syndromes has been described since decades, actually. The subclavian vein compression was described in 1939, and the pectoralis minor compressing the axillary veins was also in year 45. So we're not talking about something new. And the three surgical approaches for decompression, the transaxillary and the paraclavicular, actually, and recently we shifted totally to the infraclavicular approach. And why is that? Since its early description in 1998 by Molina, we found this approach to be very, very nice and suitable for the venous thoracic outlet syndrome problem, because you have clear visualization of the whole vein. It's a very straightforward, simple procedure that solves the whole problem. So we found recently that in the JVS, many centers around the world actually are shifting towards infraclavicular, to that particular approach. And they found that it's in comparison to the supraclavicular approach, appears to be more safe with less complications. It's a direct approach and safe, and allows venous reconstruction. You have clear visualization of the whole vein. And most importantly, that both operators, actually the operator and the assistant, can see the field adequately, which is not possible in transaxillary or supraclavicular, which is a very narrow space, and only the operator barely sees the structures. And also we found it can be an all-in-one comprehensive approach to solve both if the subclavian axillary, the subclavian or the axillary, or both of them are actually compressed. You can release the pectoralis minor from the same infraclavicular approach by extending laterally. And our experience actually included 20 patients diagnosed. Of course, more females than males, mostly in the dominant arm. 3 cases only had cervical rib, and 10 patients had associated neurogenic symptoms. 5 of them only were documented in nerve conduction studies. And we classified them for ease of to proximal type, including compression at the scalene triangle and costoclavicular, and distal type. So we operated 10 patients who actually consented for doing the procedure. Infraclavicular approach was done, guided by intraoperative venography. 5 cases with proximal type. The subclavian was released by anterior first rib resection via medial incision. And the distal type, which is the subpectoral pipe, was done by pectoralis minor incision through a lateral infraclavicular incision. And we had 1 patient with dual type, which was released by both first rib resection and pectoralis minor release. So post-operative was, they had all uneventful recovery. Next day discharge on non-steroidal anti-inflammatory drugs. They started simple physiotherapy after 1 week, and all patients reported full relief of symptoms, including the neurogenic ones who were operated. So except 1 who had partial improvement but had persistent edema, we re-investigated him, and we found that we missed a pectoralis minor axillary. We released the subclavian, but we did not release the pectoralis minor. So we took him to theater after 1 month, and he had complete relief after that. So to conclude, Mr. Chairman, ladies and gentlemen, non-thrombotic venous thoracic outlet syndrome deserves to be treated as a specific entity. It occurs in the dominant arm in young active patients, presents with intermittent manifestations, so it has to have high clinical suspicion, and dynamic studies are mandatory for diagnosis in the hyperabducted arm. And the infraclavicular approach, besides being simple and straightforward approach, avoiding the complications, offers an all-in-one approach to treat the whole thoracic outlet area. Thank you very much, and I would invite you all to visit as is having applications for our IVLA, the newly born site. Thank you very much.